everybody. It looks like we've got all the members that we were expecting for today. As I was just saying with the holiday, I know a few people were out this week and weren't able to join us. But thank you to those of you who were able to jump on, especially if anyone's taking a little time away from a week off to join us. I can jump right in. I wanted to start by just acknowledging, as I said in my email, that we have a couple new members who have been nominated to the Advisory Council on Affordable Healthcare. The legislature wasn't able to go through the full confirmation process for those members. So that's still pending. But as I said in email, I thought, given that we've got a few vacancies and these are seats that are open, wanted to move ahead and allow or invite and extend the invite to those new members to start joining us so that we can benefit from their knowledge and benefit from as many advisory council members as possible. And also just to kind of get things rolling before the legislature reconvenes again, either in, maybe a special session or certainly the second session of the legislature in January, because we've got a lot going on and want people to be up to speed. So I thought I would start off this meeting with a round of introductions, just so we could put faces to names, especially for Randy, who's a nominee who's joining, Maureen Hensley Quinn, who's the other nominee. Let me know she wasn't able to make it today, so we can maybe do the same at our next meeting in September. But thought that would be a good way to start. And we also have another sort of guest joining us for today, Rudy Rudinsky, who's a student who's doing a field experience placement with us for this summer. So we'll have Rudy introduce themselves as well as we go around. So I should have double checked that everyone can hear me, but I think I just saw Rudy wave. So hopefully that's a good sign that our microphone is working. So maybe we'll start off here in the room, although most of you know me already, but the staff are new for some folks. So we can start there and then I can call off for the members who are on virtually, which is everybody today. I had a feeling that might be the case. So Meg Garrett-Reed here, Executive Director of the Office of Affordable Healthcare. Pass it off to Katie.
Katie Seneschal, she, her, Senior Analyst at the Office of Affordable Healthcare.
And Kaylee Shea, she, her, Policy Analyst at the Office of Affordable Healthcare.
Perfect. And just looking at who I see first, Katie, you want to introduce yourself?
Hello, Katie Fulham Harris, Maine Health.
Thank you. Kevin?
Hey, good afternoon. Kevin Lewis, CEO, Community Health Options.
Perfect. Kate, Endy?
Hi, Kate Endy, she, her, and I am with Consumers for Affordable Healthcare.
Thank you. And Trevor?
Hi, everyone. This is Trevor Putnaki. I'm with the Healthcare Purchaser Alliance of Maine.
And Jordan?
Hey, Jordan Rhodes. I'm with Maine DHHS.
Perfect. And Jeff, I see you on. I was just talking about the kind of transition to nominees and new members, but glad to have you on as well. I wasn't sure if you would be able to make today's meeting, but glad if you want to introduce yourself to share.
Yeah, no, thanks. Jeff Sanford, I'm a VP of Finance at Northern Light Health. This will be my last official meeting, retiring tomorrow from Northern Light Health, and wasn't sure I needed to attend, but I'm happy to be here.
Well, thank you, Jeff. I'm glad we got the opportunity. I wasn't sure that we would to say thank you to you for all of your time and service on this council. It's been great getting to know you and getting to engage, especially on some of the conversations around quality of care and delivery system reform. So really appreciate all of your contributions, and yeah, congratulations on retirement and wish you all the best. And it actually sets up a nice transition over to Randy, who is going to be nominated and hopefully, assuming all goes smoothly, which I expect it will, to fill the seat that Jeff is vacating.
Well, good afternoon, everybody. I'm Randy Clark. I'm the president at Northern Light Sebasticook Valley Hospital. So my pleasure to be here this afternoon. And it's a little bit about me. I'm actually a Maine boy, so grew up in Maine. I've been working in healthcare for almost going on 29 years now, hard to believe. And have a plethora of experience in finance, and recently I've just taken over the president's role over like 3.5 years ago. Unfortunately, I was the president at Inland Hospital just at the recent closure, so I do have some experience with hospital struggles that we're having in the state of Maine, and so I can share that experience. And but also I'd like to learn from all of you as well and listen. I think that's one of the qualities of leadership that we all need to stop and think about for a little bit. And so I do like to listen and learn, and but also share what I've learned as well. So I look forward to this being part of this group, and whatever I can do to contribute, I'm happy to do so.
Wonderful. Thanks so much, Randy, and good timing. I think there's some slides later on around kind of hospital financial performance, and I'm sure we'll be talking more about operations and considerations. So will be really great to have your perspective on those issues. Rudy, would you like to introduce yourself and share a bit about the project that you're working on with us this summer?
Sure. Thanks, Meg. Hi, everyone. I'm Rudy Rudinsky. I'm doing my field experience here at the Office of Affordable Healthcare. I'm getting my master's in public health from USM. I also work full-time at OnPoint Health Data as an analyst there. I've been there for about 3 years. So this summer, working with Katie, Megan, Kaylee, I'll be looking at behavioral health spending and reimbursement in Maine and comparing that to some other states that are similar. And then we'll also be looking at the best ways to analyze the data that we have available to us. So looking forward to the session today. Thanks.
Great. Thanks, Rudy. And yeah, it's been fun to welcome Rudy and get their perspective as someone working in claims data in different contexts and with different data sets, but helping us to learn a little bit more about those analyses, but also on the behavioral health front, just wanted to acknowledge, I think part of the reason we identified that and built out that project in collaboration with Rudy was the feedback from this group, and that we hear in a lot of conversations about, gaps and challenges in behavioral health services for people in Maine that can lead to use of emergency departments or hospitals when that's maybe not the best setting for care for those individuals. So trying to think a little bit and understand a little bit better what role financing plays in those challenges. And then, as Rudy said, kind of taking a look at other states and seeing what we can learn from them about potential solutions. So doing that with a lot of collaboration from Jordan and the DHHS team as well, given the work that they do on that front. So thanks everyone for taking the extra time to go around and make those introductions. Really nice to just take a step back and kind of reset a little bit as we move into this new season as well, following the end of the legislative session last week. So moving right into the slide deck, I can go past our agenda and maybe jump right into the substance. We wanted to give an update on our analytic planning. I think it was 2 meetings ago, we had shared a sort of next round of dashboard work that we're doing in collaboration with Maine Health Data Organization, and had committed to come back to this meeting with an update on how that work is going. So I think I will hand it off to Katie, and if you want to take over for this section of slides.
Absolutely. Good afternoon, everyone. For our new members, and just a refresher for everyone, I'm happy to show this graphic that shows our analytical planning for the work that we have previously done and completed with collaboration from MHGO and the Maine Quality Forum, as well as work that's in progress and work we expect to do in the future. So today we'll be reviewing the facility level payment and utilization dashboards, which is the phase 3 of a dashboard project. So in the fall, we completed the hospital payment and utilization dashboards. That was looking at hospitals in total and aggregate across the state. This next set of dashboards will look at the facility level, and then the ongoing dashboard work we have with MHGO is also a professional services and payment utilization dashboards. Those we expect to be ready a little bit later in the year.
Maybe I'll just add on to that, just because we do have new members, just sort of reiterating these dashboards that we published back in the fall use a set of methodology to quantify and report out on spending utilization and a calculation of payments per unit, essentially, that, as Katie said, we're limited to hospital spending in the aggregate. And so I just want to say these really are new iterations and new, more detailed visualizations of essentially a similar methodology rather than a brand new analysis. Just to give that little bit of extra context, because we're jumping ahead a little bit and talking about kind of new functionality, but that's because these are built on a methodology and a structure of work that we had kind of discussed and worked on with the advisory council back last summer, honestly, about a year ago at this point.
Absolutely. Thank you for that context. And for anyone, I'm happy to follow up actually this meeting to everyone with another link to those dashboards and the methodology should anyone like to review some of those things. As Meg said, we are working with MHGO to create these hospital level dashboards that measure payments and utilization across hospitals in Maine. Our purpose is really to be able to identify and describe variation in payment and utilization across these facilities. Some of the metrics we will use, again, we're building off of the methodologies used in the fall, but these will be looking at total payments, cost sharing payments, and payments per unit by either hospital inpatient, outpatient, or professional services. We'll also be able to take a look at utilization at these facilities and then drill down a little bit and be able to compare service level total payments, cost sharing payments, payments per unit, as well as service level utilization. And that will actually be able to compare at the CPT or DRG level. And then just to reiterate, these dashboards, the data that flow into these dashboards come from the MHDL All Payer Claims database, specifically capturing January 2017 to December 2023. And as was mentioned in the last setting, this database includes all Medicare, all Maine Care, and about 70% of the commercial population. So we think it's actually a very good representation of payments and utilization in Maine, but just wanted to flag, we don't have 100% of the commercial population for the all payer claims database. And to provide an update to our timeline. So today is July 2nd. We are hoping in the final discussions here to finish up the hospital level analysis of these dashboards. And then, as I mentioned, there's also going to be a non-hospital provider type analysis that will be looking at places like ambulatory surgical centers, FQHCs, other non-hospital settings, also looking at their payment and utilization. Our goal is to present updates to you today on the functionality of these dashboards. And then as we work to finalize them, reach out to you all to get some of your thoughts and impressions on the dashboards, and then eventually be able to present them at our public hearing in the fall. So today, as I said, we are in final discussions and review for the hospital level dashboards with MHGO and their data vendor, HSRI. And I'd like to take the opportunity today to review the functionality of these dashboards. So when we are at a point where we can share them, everyone is maybe in a better equipped setting to click through and see what different things they can look at in the dashboards.
Yeah, so just to reiterate, I think wanted to provide a little bit of an orientation to what these look like because they are complex. There's a lot of data and a couple of the tabs here in particular benefit from a little bit of an introduction. And MHGO and their vendor are still doing quality checks on the data and things, so we weren't quite ready to kind of give a live demonstration, but do want to sort of reiterate that we will share a draft version of these with the advisory council like we did with the previous iteration of the dashboards to kind of let everyone just play around in there, let us know if you have questions about the display. I think that was a helpful exercise last time around to kind of surface issues and help us think about and understand them. So again, yeah, this is a little bit more about what's included and what it looks like, and we're not really doing a dive into the data itself in this presentation just because of the kind of status of the project at this point.
Absolutely. So as Meg said, this will just be kind of an overview of what you all are able to see. I threw some highlight onto these slides to try to help orient to what we're talking about for each slide, but just in general, the dashboard is set up into two main figures. On the left-hand side, you'll see cumulative either payments, utilization, or other metrics over time. So that will be the 5-year, 6-year period, 2017 to 2023. And then the right graphic will show year-over-year change at the facility. Or, for example, this tab is the health system level. So first off, some of the different metrics that you'll be able to filter through here would be the payments, health system payments tab would be total payments, cost sharing payments, and then payments per unit. And to the left of that is a health systems tab where you're actually able to select which health system you'd like to display. By default, we will be able to show all of the health systems at once, unlike our hospital level tab. There's more hospitals there, so it's harder to actually see that. So right now, showing 5 hospital systems, we're working to essentially make Covenant Health System include both St. Mary's and St. Joe's at this time. So that's why St. Joe's is showed and St. Mary's isn't. But this more so highlighting the idea that you can filter 3 measures, being total payments, cost sharing payments, and payments per unit.
You just answered Kevin's question.
Oh,
He's just
great.
asking about the St. Joe's, St. Mary's. So
Yes,
it
yeah.
will in the final version is the answer, Kevin, but it does not yet right now.
Yes, and thank you for that flag. I think that is another example of how invaluable all of your review is in these dashboards. So anything like that that comes up in your review, please let us know and we can work with our partners to get that fixed. Yes, Katie.
Thank you. I'm sorry, I'm on my phone, so I can't type into the chat. Just how are you going to accommodate hospitals of different sizes in your hospital specific dashboard? Or are you going to be comparing critical access hospitals to Eastern Maine Medical Center and Maine Medical Center? And secondly, how are you going to accommodate the variances in payer mix and acuity by hospital?
Want me to take it?
Yeah, go ahead.
Yeah, so we in the hospital payment tab, which Katie will get to in a couple slides, we allow the users of the dashboards to make their selections for comparisons. You actually, because there are so many, we're not able to display all of them at once, but we didn't make a decision to sort of display or categorize hospitals and give that to the user. I think we wanted to make these as flexible as possible for any comparison an individual wants to make. We definitely understand that these are not apples to apples comparisons, particularly when it comes to the question about acuity. That's part of why we wanted to release these at the same time that we were releasing trends in service, because we know that, you know, comparing a Maine Medical Center with a different level of services at a high level to a small community hospital in Maine is obviously not an apples to apples comparison, but this does allow for a dive down to actually look at correlating and similar, you know, levels of complexity at a CPT code level for comparison. In terms of payer mix, there are options to disaggregate this by payer. So maybe I can hand it back to you for the answer to that question, Katie.
Absolutely. And if you click to the next slide.
There you go.
Perfect. You're actually able to click down and select the payer that you would look at. To your point, Katie, our dashboards are not at any point showing, you know, what portion of net patient revenue is paid by any specific payer at that time, but you are able to isolate the payer when looking at health systems and the hospitals and the trends by service tabs to be able to understand payments and utilization among those members. So here we show that there are 7 total payer types. 5 of them are distinct. We break out Medicare as we did in the fall dashboards to show original Medicare and Medicare Advantage for people that are interested in those payer groups. And then finally, on each tab, you're able to also click through service categories. So here, the first 4 tabs look at service categories in large categories. So this would be inpatient services, outpatient services, and professional services at these facility types. And then our next tab over in health systems will be able to show utilization at each of these places as well. And here you can see that, to your point, Katie, utilization varies at each of the health systems, and you'll specifically be able to see that variation better in hospital payments. But for, oh, perfect. And here's the hospitals tab. As you can see, there are many hospitals that you can choose from. For the purposes of visual display, I believe we landed on 9 hospitals that we could show at any given time. We don't want to go above that just because it will get too messy. The first default is just alphabetical. So the first 9 alphabetical hospitals will be shown. We're going to include a clear all button to be able to quickly, you know, clear those if you don't want to look at those and select the hospitals that you would like to drill into here. On the hospital payments, you also have the opportunity to look at total payments, payments per unit, and cost sharing payments, as well as filter the different payers and service categories. And then last but not least, our trends by service tab. This is where you are actually able to drill down into specific either services at a subcategory, a service type, or at the DRG or CPT code level. We will come out front and recognize that this dashboard tab is slightly clunky to get through, and we worked with our partners at MHGO and HSRI to talk through some of the different ways to try to alleviate some of this clunkiness. Given the detail that we are drilling down to, it's hard to create a seamless dashboard example. But in this trends by services tab, if you take the time to filter out, what measure you're looking at, your payer, your measure value, and your subcourt categories, you can then spend some more time in this bottom area looking at, at the service level or the service type, different payments and utilization. And I see, Jeff, you have your hand up.
Yeah, I couldn't attend my last meeting without getting my hand up and raising a question. No, this is, really good stuff, and I appreciate it. If you could roll back to, I think it's the health system payments, a couple slides back. Yeah, that one's good. That one's fine. So I was struck by this because our current lived experience is different than what I see on this graph, right? And I'm at a loss as to how to reconcile the fact, that it's no real secret we're struggling at Northern Light Health, and yet we appear to have the highest payments per unit. We have a really high government mix, and other issues in play. So I am just puzzling over this, and obviously we can't solve that here today, but hopefully, when we get to, driving this around, we can sort of, figure out either, actually, this is really what it is, or there's, something else at play. And, Katie raised, a couple of good points in terms of, how does this measure, risk? We know from our participation in payer risk arrangements and Medicare Shared Savings Program that our risk scores tend to be substantially higher than most in the state of Maine. So maybe that's at play. I'm just can't quite connect the dots here on this. So, but it's great work and interesting, and someone, not me, will have a lot of fun, pulling this apart and getting deeper into it.
Yeah,
Thanks.
Jeff, I would just note that in our own claims analytics program, we do find prices at Northern Light to be higher relative to other facilities in the state. So this actually looks pretty consistent with what we find in our own claims analytics. I think there are legitimate reasons why prices would be higher at a Northern Maine Medical Center or Eastern Maine Medical Center than other facilities, but they do appear to be higher.
Well, let's be, put a fine point on that, right? Prices is one thing, payments are something else, right? So, Trevor, if you're referencing payments, then we're talking
payments.
apples to apples. But if we're talking about prices, right, that's that prices are becoming a fiction, I'll say.
That's a fair point. We look at payments, right? We look at claims data when it actually gets paid out. So consistent with this. Prices, it's hard to tell. I mean, you can look at the listed prices, but you're right, they're sort of a fiction.
Yeah, I was just going to say in response to your question, Jeff, on this particular screenshot that we're sharing, commercial has been selected as the payer here. So this is just a representation of payments per unit for commercial. So that might help to resolve the question. Yeah. And I totally hear, both you and Katie on the ideas of all the different ways we could overlay other considerations on a dashboard like this. I mean, as I do with a lot of our products, where this is specifically a dashboard of claims information from the APCD, and it is already hefty, as we noted. There is a lot on that service category. So I think we are mindful, of just like the complexity of a single visualization of a concept. And, we've never said like, here's one graph that answers every question, or here's one graph, here's the truth to take away from it. I think it adds more to the conversation as we try to do with each and every product that we put out. But the other thing I'll just say is we also face challenges sometimes in accessing reliable data for some of what you've shared. We don't actually have a kind of agreed upon clear data source for payer mix at the moment, for example. And there's ways you can back that out of this data, but given the gap in commercial payments and the fact that we don't know how those maybe disparately affect some providers in the state versus others, we can't really reliably calculate that from claims data. So that's something we've been thinking about and, talking about a bit with others, and certainly, are open to it, would like to understand better ourselves. But unfortunately, right now, there's not sort of a go-to place where we can just pull that number and utilize it. So just another kind of consideration there.
Thanks,
Katie,
Mike.
I think, yeah. Oh, sorry. Did you have more to say, Jeff?
No, good. All set.
Thank you. And Katie, looks like you have your hand up.
Thanks. I'm just curious of what is your goal in doing the out-of-pocket cost out-of-pocket comparisons and by hospital? That I'm struggling with that one, and what that tells anyone other than what types of insurance people may be on.
Yeah, I think it is something we included in the first set of dashboards for that reason, just to sort of give some understanding of maybe the difference between what does looking at a total payment mean in terms of an individual consumer, or the average consumer, I guess I should say, their kind of experience of cost, because obviously it tells a little bit of a different story if total spending is going up, but consumer out-of-pocket payments are staying level, for example. I think it's a good point that, that might have more limited applicability in an individual hospital by hospital context. We really basically had just taken the metrics that we used for the first set of dashboards and moved them over into this one. So happy to kind of consider that more and give more thought to that if there's a feeling that could, obviously those amounts are influenced by negotiations with carriers, for example. So I understand that point.
Yeah, they're influenced by negotiations between the employer and the carrier as the employers purchase their plans. So that's the piece that's missing for me. Like, because the focus has been based on hospitals, that piece is not, hospitals don't control the out-of-pocket component. So I'm trying to, that's the piece I think that may warrant further discussion.
Yeah, and I think especially in a context, whether we're talking about a co-insurance amount that is actually influenced by underlying negotiated rate versus a copay that truly is based on, the choice of the plan design, I think are valid points. We're happy to, give some consideration, I guess, to that and the value of it versus whether it is not misleading, but, potentially just not useful for folks to look at, and if they may take away a different assumption for that. Like I said, it was really just a default of sort of a carryover from the top level analyses that we've done.
Thanks.
Do we have other slides in that?
I think the last one I just wanted to show is trends by service. You're also able to look at graphs, but as we mentioned earlier, the level of detail you can get to here and comparing different facilities can quickly get complex, which is why I tend to go to the table first and just want to highlight the data suppression policies are in place here. So there are times when you may not see data and don't understand why, either in the table or in the figure, and just a call out that we're trying to label that. When that happens, it will definitely be labeled in the table. But if you end up getting to a space that you have, clicked quite a few different levels here and you're not seeing data, it's just because of data suppression guidelines, where there is low utilization of a specific service at a specific facility that will, trigger some of those suppression policies.
And that's a little bit of the cause for when we refer to the clunkiness. We made the determination that the menu options for a given hospital or group of hospitals. If there is no data for a CPT code, if it's only not in use at that hospital for whatever reason, or not in use for a given period of time, it just doesn't appear. So that's why it sort of requires this clearing out of the secondary options, kind of making sure you have your selections in the second category, and then being able to delve a little deeper. So it's been a complicated one to negotiate, since we know that it's not as though everyone has a consistent set of codes across all services that are in use all the time. But we did want to essentially provide as much data as possible in this section, rather than only selecting a handful that are in use at every facility and including those. I think that might be our last slide in this section. So I'll maybe just pause in case there's any other initial thoughts or reflections. Otherwise, like I said, we'll be sharing sharing a version of the dashboards, a draft for everyone to spend some time in, and then share any comments or feedback that you have with us before we finalize and make these public again. And I think when we do that, maybe we can share a few tips and tricks, particularly for navigating this trends by service tab. Anything else?
Yeah,
Yep,
I
Kevin?
can't seem to raise. Yeah, thanks. So this may be for later, but two observations. One, I see a real use case of what you're constructing in terms of how we can help facilitate the movement towards, I'll just call it value-based arrangements in general, and getting away from the volume-based. And that's easy to say and much harder to do, and that's where I think the data could be helpful. So trying to think back from the desired endpoint and what data might help facilitate our migration as a whole market and ecosystem in Maine, not looking at any particular relationships, but just in general. That's one of the, hopefully one of the use cases we get out of this. The other comment is to what extent we can shine a light on additional capacity that we need in the community to help hospitals create much needed capacity and reduce length of stay, improve a lot of the metrics that are stymied by the fact that we have this essential bottleneck in terms of whether it's skilled nursing facilities or other means, more appropriate levels of care that would really help, I think, everybody in the market. So I think that's part of what you're working on in the broad scheme of all the analytics, but wanted to raise that as another potential use case.
Yeah. And I think, are you thinking specifically being able to look at particular services in that and in their utilization in a hospital setting as contributing to that? I want to make sure if there are any takeaways that we can think about either for this round of dashboards or future ones to get at that issue.
I don't have a really quick answer to that, other than to look at perhaps the whole constellation of services, without regard to the bricks and mortar, just looking at a person's end-to-end services for a particular, call it a CPT, and look at before, everything that's in that DRG that's related to that, and okay, what has to happen really outside the walls of the hospital, and how do we facilitate capacity there to free up capacity within the hospital to really deal with what they do best. That's where my head's going with that.
Gotcha.
I don't know, Katie, you probably think about this a lot.
Yeah, no, I love that. I love both of your points, Kevin. And I would add, I think one of a metric that could easily, I say easily, I think we could generate would be excess stays in the hospital beyond, the median length of stay for a DRG or whatever. There are measures out there that would at least allow us to understand how much hospital capacity is being used by people who no longer need hospital level care.
Yeah, 100%, Katie. The hospitals get gummed up with, folks who, should be in different and better settings, and that post-acute, whether it's a skilled nursing facility, home health care, whether it's, patients, bedded in the ED. I mean, I agree, Kevin, a lot of opportunity there that would help everybody, right? That the worst place for many of those patients is in the hospitals.
Yep, absolutely. And I'll just say, by way of a brief update from our last meeting, I think the last meeting when we had the conversations about access measures, and we showed that map, kind of heat map of unnecessary ED utilization. Katie and I did have a follow-up conversation with some folks at USM about that. The original researchers who had authored the paper that was included with have moved on now. And I think it's fair to say the basic outcome of our conversation was this is not something where a methodology exists and we could just do a data refresh and bring that back to you. We had hoped that might be something we could kind of turn around quickly and share, because I know that there was interest from the group. So that's why there hasn't been an update at this meeting, but it is something that we're still thinking and talking about. So glad to continue, and maybe even for the next meeting, we can try to come back with some ideas, because really we've mostly looked at utilization as a high level metric and as a way of kind of better understanding trends in spending. And I think that gets at your first point, Kevin, about maybe thinking about this intersection where there is sometimes an inevitability around decline in utilization, necessitating perhaps an increase in price in some settings where you're just losing economy of scale, and thinking about why that might be an argument for different payment methods and approaching things differently than through a fee-for-service lens. But I also think differentiating sort of proper or desired or unavoidable utilization versus utilization that is either unnecessary or sort of not in the correct setting is definitely a worthy use of our time. And I will just call out again, I think we talked about it at the last meeting, but want to acknowledge that I know the Maine Health Aid Organization board has had conversations about this at their board meetings this year. So we'll also, kind of check back in with Karen Lee and have some conversations about what they might have underway. Don't want to duplicate efforts or get in the way of that, but we can maybe coordinate on roles and continue to look at that as an opportunity for collaboration between our organizations. Great. If nothing else, I can move us along to the next set of slides that we have, which I will give Katie a lot of credit for helping with. She's been doing a lot of work in this space, but I thought I'd take over just so she didn't have to talk for the whole meeting today. But she will kind of jump in and support me, I'm sure, at points. We wanted to bring up and have this conversation about hospital financial performance. Ideally, I would say provider financial performance, but really hospitals are the one sector of providers where we have access to financial data, but brought up by Katie and by others, I think in the context of, as we think about affordability for consumers and as we think about policy ideas, staying mindful of the context in which hospitals in the state are operating and sort of their current financial situation and pressures that they might be facing, and wanting to move towards an approach that allows us to have sort of an agreed upon way of measuring and assessing the financial health of our hospitals and health systems in the state of Maine. So we kind of put this presentation together with a few different sections and areas of focus. The first is just to talk about sources for this data. There are several that are used by different people in different contexts, and so we've done a bit of a deep dive to better understand pros and cons of each of those that we wanted to talk through with you all. Thinking about metrics, and there's a wide range of metrics that can be used for assessing financial performance, but thinking about maybe identifying a few key ones that can kind of, again, be agreed upon as giving a solid picture of different dimensions of financial health for a hospital or health system. And then finally, analytical considerations. Terms can be used, the same terms can be used, but actually using a methodology that are measuring different things and yielding different results. So thinking a little bit about kind of taking steps towards agreement on the actual methodology for some of this work. So before I dive into those sections, we also just wanted to acknowledge another complication here, or extra layer that needs consideration, is just the difference between assessing hospitals at actual individual hospital level versus a system level. I think looking at a hospital level can provide some benefits, especially if you're thinking, as Katie was saying, about comparing maybe like hospitals, wanting to think about kind of a cohort or peer group that might have either similar distribution of payers, similar bed size, similar acuity of patients. And that's certainly doable, but want to acknowledge that sometimes when looking at a hospital level and including analyses of hospitals that are part of a health system, you can lose a little bit of the picture because systems tend to have sort of more investment, more borrowing captured at the system level. There can be transfers of funds between individual hospitals to systems that can sort of change the way that hospitals look in isolation. So we'll try to kind of differentiate that, I think, throughout analyses. And I think the conclusion we've kind of come to is it's generally helpful to do both. I mean, looking at the system level in particular also just leaves out a lot of our independent hospitals here in the state of Maine. But as we're kind of thinking through and talking about this, we find it helpful to look at both levels. But there are some considerations in thinking about sources for that. I'll move through this slide, but if anyone has questions, please just raise your hand or give me a shout, and I'm happy to pause. So looking at kind of the primary sources for measuring hospital financial performance that we found in conversation with national experts and in some reading, the first we've described here is audited financial statements that hospitals and health systems generally need to provide for their financing and for transparency. Lots of advantages to audited financial statements. In the name, they are audited, they follow general accounting principles, quite timely in comparison to other data sources, and pretty rich in terms of the information they provide. In particular, audited financial statements, we can generally derive information both about an individual hospital and its financial performance and the system as a whole. For cons, they can be a little bit labor intensive to work through. There are some data points that are a little bit easier to pull out, but a lot of information in kind of non-standardized formats that take time to work through. And then a big issue or challenge with audited financial statements is that we are really lucky in the state of Maine. MHDO collects a standardized template for financial information from audited financial statements and publishes that information annually, but many states do not have that. And even in states that do collect or publish this data, there's no standardized warehouse. So really, there's not a great way to kind of compare state to state using audited financial statement data. So that's why, moving on, I think the other most common source that we see or that we've kind of come across in our work is Medicare cost reports. Those are submitted by Medicare certified providers, so really touch essentially the vast majority of all providers or all hospital providers, and are used for determining government payment rates and funding types. So these do serve a different purpose than audited financial statements that are intended to sort of reflect the financial status and performance of the hospital. A big advantage to them, though, is that they are comparable across states. So that is a big reason why I think they are used. And we'll talk a little bit about where these have been used kind of in recent years in looking at hospital financial performance here in Maine. But there are some downsides to this data. They only look at hospital level information, they're less detailed, and there is a delay on their publication. So don't give us as timely information as the audited financial statements do. I think the answer on all these is that they're all a little bit difficult to work with, but the National Academy for State Health Policy has provided a kind of data set that they've pulled from Medicare cost reports and done some cleaning to that makes that data a little bit more accessible. I'll go maybe a little bit quickly, I think, through IRS 990 forms. Those are limited to nonprofits for tax filing. In general, resource intensive and tough to use and provide some data points that don't exist in other places like executive compensation. These are available through Maine DHHS for all Maine hospitals, but I would say haven't really risen to the top as a main source of data, given that we have audited financial statements. I think some states see these as a fallback if they don't have AFS access, but we are fortunate here in Maine to have that data. And then finally, rating agency reporting, which is produced by third-party analysts who are looking for information and sort of assessing information for credit rating purposes. again, not standardized data and can be difficult to access, can require payment to access, or be hard to kind of find and dig up. So I would say we've particularly focused on the audited financials and to some extent Medicare cost reports when thinking about cross-state comparisons, but really, our assessment and takeaway is using the audited financial statements from AFS or their AFS reports is really kind of our preferred way to go, both because of the timeliness and the comprehensiveness of the data, but also because of the work that's gone into refining, I think, the methodology for those measurements and the methodology for collecting data over years that MHDO has been working with hospitals and health systems and Maine to kind of understand their structures and operations and try to reflect that as accurately as possible. But I will also say, as we say about every single source of data we interact with, there is no perfect one. There's nothing that tells us every single piece and that is fully, reflective of every single consideration. But I think we generally think that audited financials are the best option that we have available to us in terms of actually understanding what is the financial performance and kind of status of Maine hospitals and systems. There's not any questions there. I'll keep moving along. So then going sort of at the next step further in thinking about the data that is available from Maine Health Data Organization, we wanted to put together kind of a subset of measures that stood out to us, again, based on conversations with folks nationally and some research that we've done that felt like a good set of key metrics that, again, tell a good, tell as complete a story as possible about hospital financial performance, but maybe not including every single metric available. MHDO does have a really rich data set, and there's a lot that is included in that. But I think there's always a balance with data between, reporting everything, but maybe getting a little bit lost in terms of the conclusions or takeaways. So this was kind of our attempt to put that list together, but I'd love to pause on this one and see if folks have reactions to this list. I think I won't read through because I don't think there's too much more to add that we kind of haven't included here, but just trying to think about these kind of 4 different categories of profitability, liquidity, debt capacity and solvency, and then capital investment to capture multiple different dimensions of what does kind of a healthy, well-positioned hospital or health system look like. So I suspect there may be thoughts on this. Would love to hear if there's either kind of, adjustments to these that folks would recommend, or if there's anything that anyone feels like is really missing from this list that you view as a key or critical metric.
Hey, Meg, I'm sorry, I'm not able to raise my hand. It seems to be disabled for some reason, but my only comment is on the total margin. It might be more helpful to have it be adjusted to exclude income from investments, which I think would skew the picture or the results that we may be drawing from this data in the event there's a really bad year in the market or a particularly good year in the market that makes a system look like it's doing better or worse than it is in reality.
Yep, and I should have maybe covered this next slide first, so apologies for that. We'd actually put together a slide about EBITDA and considerations for incorporating EBITDA into, I think it'd be total margin, operating margin, and probably one of the debt service calculations that incorporates earnings. But kind of this question around whether or not to exclude from earnings interest, tax, depreciation, and amortization. Again, I won't read through this whole kind of list or discussion, but our understanding is helps to regularize a little bit comparisons between systems and eliminate or reduce some of the impact that kind of financial structures can have on these measures. So I will say our understanding is the MHDO calculation does incorporate, I think, at least interest and depreciation in their calculation for operating and total margin. But we're, really open to conversations. I might have missed one of those.
Just total margin.
Oh, total margin.
Yeah.
Okay, so only in total margin, not operating. Yeah, of course. Thank you. Sorry, that was silly of me. But so, I think we'd want to think about, is it worth making an adjustment to that and sort of calculating in a slightly different way, but definitely understand the desire or the benefit, I guess, to using that methodology for the calculation.
Yeah, I think these are like as a core measure set are all good measures. I don't know if you're open to adding additional measures, but I think like bad debt as a percentage of operating margin or operating expenses, charity care as a percentage of operating expenses would be interesting to see across hospitals as well.
Are there any other thoughts or reactions to this list?
Yeah, I think having an EBITDA measure would be good. So, it's sort of a quick and dirty measure of positive cash flow. It's not perfect, but
Also, I'm glad to hear that you also pronounce it EBITDA. Jeff, I got very in my head about EBITDA versus EBITDA, so I understand that's a point of debate among some financial analyst folks.
you got to remember I grew up in Western New York, which is a very sort of Midwestern accent, and we tend to be a little harsh on our. My favorite one is aunt versus aunt. Aunt is the correct way of saying it.
Oh, got it. Okay. If I say aunt, so maybe I'm wrong. Maybe I should just say EBITDA. We can add that into as another decision point, is aligning on what is the correct main pronunciation of this acronym. Okay, great. Well, this is another I think we'll be revisiting and doing some more work on. So as folks reflect, if there are other things that jump out to you, please let us know, and we're happy to have more conversation about it. In terms of analyzing financial metrics, just a few other kind of learnings that we wanted to make sure that we reflect are part of our thinking about this category of analysis, is thinking about the volatility of these metrics. I think in particular, a measure like total margin that's inclusive of so many different sort of sources of revenue, it can really vary from year to year. So this is only an illustrative example. Don't mean to call out Eastern Maine Medical Center, but this is one where we saw, these really extreme or fairly extreme changes year to year. And of course, that also covers the COVID time when we know there was significant drop in utilization followed by, funding coming in from the federal government and other sources to offset that, that can really, just again, create a lot of volatility. So trying to the maximum extent possible to think about looking at averages over a course of years as we're thinking about these metrics feels important, which I think we put on the next slide. Thinking about multiple years. And that's why we want to look at multiple metrics too. It's been a learning for me that it's one thing to say a certain number of days cash on hand is a positive signifier, but actually, if you have a certain number of days cash on hand, but then an average age of plant looking differently, there's sort of a balance and relationship between the metrics, which is part of why we wanted to think about looking at kind of a key set of them rather than identifying one or two individual ones and using that to try to take away the picture of finances of a hospital or health system. Thinking about medians here, I think that's a straightforward one. Thinking about influence of unrealized and realized gains and losses in investment is another. Thinking about exclusion of unrealized gains or losses to kind of help smooth some of those economic changes that can influence what margins look like for folks. This relates back to some of the points others have made, but trying to be mindful of the external factors that can influence financial performance and thinking about making comparisons between kind of like or similar facilities. And then as we try to do with everything, thinking about the broader context that can influence performance. Katie, I see you've got your hand up, so I'll pause there.
Thanks, Meg. So I think a question for you is what you think. So the unrealized and realized gains and losses in investments, that's not cash. Mm-hmm. So trying to understand what your intent is there. And I guess we would have no problem including non-operating gain or non-operating income as part of this. But our team, I brought this to our finance people and they said there really was, they couldn't see any utility in looking at at gains and losses and investments that are not cash and not supporting sort of the day-to-day operations of the organization.
Yeah, I will say, I think it can depend, and it also might depend on the specific analysis that's being done. Again, whether it's like a comparison to see how there's been change among a group of hospitals over a set of time. I think maybe an argument for including them would just be this sense of having a better idea, particularly I think at a system level, of kind of what is the full financial picture, and if there are assets in unrealized or in investments that aren't reflected otherwise, kind of having that knowledge to understand maybe the risk to the system, or just a sense of what capital is available to them is the reason I would say, we wanted to put it on the table, or at least discuss. And I'd be happy to have more of a conversation about that with your folks or others. This is all pretty new for us as we're kind of learning about it, but I think it's just a question of kind of the completeness of the picture, even if it might be a metric of, that's not immediately available assets to the system.
And it might not be available at all for it might be restricted. I feel like this is just going to lead down a path that could throw people off and suggest a picture that is not accurate. So to Trevor's point earlier, when he was talking about operating performance versus full margin performance, I would say, I'll just say again, we have no problem if you want to talk about non-operating income and its influence on sort of the full margin and financial performance. But this piece is complicated, and you may have a really bad market year that completely changes the picture for the whole system without actually having operating margin or total margin reflected at all. So I'd just be really cautious about what you think this is going to portray in terms of giving information around financial performance of the system.
Yeah, Katie, happy to jump in here, Katie. We included this bullet really because there are some calculations of total margin that include unrealized gains. And there are a lot of individuals that feel like that is, to your point, not a reflection of available funds to the system. And so just thinking of, if we are looking at total margin calculations and how they may differ, whether these types of investments are included or not included in that margin can significantly change the value of that margin. So I think this is more just not that we would be, these items are reported to MHDO and publicly available, separated out. And I don't think the intent would be to lift them up as a separate aspect, but just considering their influence in calculations and ratios that we may be including.
Okay, thanks.
So then I think the last sort of section of slides that we had was just to illustrate this point that I made earlier about the methodology for metrics, mattering and changing the outcomes. So in particular, we've seen a lot of different calculations and figures and medians for operating margin for hospitals here in the state of Maine, particularly over the last year or so. And as we've been digging in and trying to understand this topic ourselves better, wanted to understand how can we be seeing this kind of variation in calculation of operating margin over time. So wanted to share our kind of quick summary of a few of those different calculations or figures that are out in the world right now, just to give a sense again of the difference in some of the real in-depth nuances of the work here. So the first one that we have here is some data that was reported by the Maine Hospital Association, produced for them by PYA, a consulting firm. And I just want to be clear, this is an assumption that we're making about the calculation that we used. We'd asked a few times for methodology for that report that was released, and it sounds like they didn't have it. So Katie had done some work really digging in and sort of looking at data sources and calculations, and I think we produced identical results with this calculation. So we think it's very likely that this is what was used, but just wanted to be very clear that it's a result of kind of our own work, and we may be incorrect about that. Importantly, I'll just note too that both that MHA-PYA calculation and the NASHP work that I'll discuss later use Medicare cost report data because of that need to make comparisons state to state, which is impossible with AHS data, I assume. And from our kind of look, our assumption is that that PYA calculation used a calculation of net patient revenue minus operating expenses divided by net patient revenue. And that ended up with a median value of operating margin for 2023 of negative 12%. Over on the NASHP side, pulling from the same data set, but using a calculation of net patient revenue minus hospital operating costs divided by net patient revenue, NASHP's median operating margin for Maine hospitals was 11%. So pretty wide variation there. In between those, the MHDO calculations, for 2023, acknowledging there's also some complication around fiscal year, so we do acknowledge they are not identical reporting periods in this time, but should be substantially similar. They use a calculation of net patient revenue plus other operating expenses minus other operating income, minus operating expenses divided by net patient revenue and other operating income. And that yielded a result of a -2 median operating margin for Maine hospitals. So again, differences in the source of data can have influence here, but there's also, assumptions are thinking about the actual calculation of operating margin that provide quite a bit of variance. So I'll say I think that this is another reason why we kind of felt like we want to move in a direction of kind of creating some standardization and agreement about both what is the source of data that we're using for these kind of calculations and conversations, and then what is the methodology for something like operating margin to ensure that when we're making comparisons or having conversation, we all really understand what is that actually calculated. Because I think, for us in particular, trying to understand sort of accounting for operating expenses while not accounting for non-patient operating revenue is a little bit of a head scratcher. Pause there. Yeah, Katie?
Thank you. And I appreciate your raising this and trying to identify a single source of truth as it relates to this calculation as well, and the data sources, quite honestly. I would just say MHDO is a data source that all of the hospitals have worked with and health systems have worked with for many years. It's not perfect, as you pointed out earlier, but it is also one that I think we're all comfortable with, and we work closely with the MHDO and have over time have come to agreement with the methodology. So I would strongly recommend that MHDO, whether it's this calculation or the data that MHDO produces or other metrics that MHDO produces, that really is something that everyone has come to agree upon and to submit to every year. So that would be my perspective on this.
Yeah, thanks. Appreciate that. And it's been helpful for us. I think we've learned a lot from talking with Karen Lee and the team about conversations that have happened around refining their collection and presentation of this data. So definitely agree that's a big advantage to build on as well. I'll just move ahead, I think, just because our next slide, I believe, was just kind of a visualization of this. We just wanted to kind of show the variation over time and among some of the largest hospitals. These are peer group A hospitals as defined by MHDO. So it doesn't say a whole lot more, but just to give a sense again of how the different choices of methodology can really kind of influence the end result here. And I think then my next steps, I already touched on a little bit, just this idea of moving towards a core set of key metrics for assessing hospitals and health systems. I think this conversation has already been helpful, and as I always do, I'll see if others have thoughts after this. I'm happy to talk. So I think we may take this back, incorporate in some of the thoughts that people have shared about additional measures that we could include, and maybe do some work to come back to the group with a visualization of what the data looks like in some of these categories. We'd also like to think about identifying performance target ranges. I know as somebody who doesn't work in this world that it's difficult to know sometimes, like, is a number good or bad? And we found some data sources for national medians, but not sure that that is really helpful in this context. So we weren't quite ready to, come back with recommendations or thoughts there. But I think that's something we'll try and do for the next round, and welcome if people have sources or recommendations of where we should look to get a sense of kind of what on the hospital side, when you're looking at metrics, what is a good range to you? And then the other thing I just wanted to touch on in talking about this is, I think another challenge of hospital financial performance is hopefully we can get to a place where we feel like there's agreed upon picture of what how a hospital is performing. And again, like I said, it's kind of stability. But these analyses aren't always that helpful in the why, which is what I get asked about a lot when I interact with legislators and others. So I think trying to think a little bit creatively about, are there other metrics or means of study that help understand what drives trends in performance and variation in performance amongst different hospitals, different systems. So obviously, I think that's something that we touch on at a high level in all of these conversations, and many of us kind of talk about in different contexts as well, but trying to think about a similar approach of some agreed upon metrics or systems for kind of assessing the contributors, I guess, to financial performance and what maybe drives performance feels like an important part of the question. And I just wanted to acknowledge that maybe isn't part of an initial assessment of just financial data, because it's a broader conversation than that.
Meg, first of all, I think this is really fantastic. This is going to be such a just a great resource for folks in the state. This may be like a future state, and I'm not frankly sure how you would even report it, but in the audited financial statements for the system level, you can see transfers within the system to different entities. And I think that's a really important thing to understand. Like in our own analysis, we saw one year where Maine Medical Center had over $800 million in operating profit, but $30 million of that went to the primary care providers or the docs, and then another like 60 million went to long-term care, skilled nursing facilities. So to the degree we're trying to really understand sort of like at the system level what the health is of the provider systems, it's, I think, really important to understand the role of other entities within the system that may be operating at losses or gains, for that matter.
Yep, that's a good recommendation. Happy to take that back and give some thought to it. I will say, based on our work, like there's a lot of information in the audited financial statements, but we're finding a way to like standardize reporting is really challenging. So that may be one, but we're all happy to take a closer look at that and see if there's a way that we could incorporate or reflect that. Just wanted to call out, I think Jordan might have had something to jump in on. Sorry, I don't know why. I'm like, Katie's raised hand. Oh, maybe it's because you're on your phone, Katie. I don't know. But sorry about that. We'll look into why that's not working. But happy to either read your comment or if you want to jump in now, Jordan.
No, yeah, I don't know what's going on, but it was acting up in another meeting as well, so it might be my computer. Yeah, I was just going to say, all those are ratios, and I think really helpful ratios that contain a lot of useful information. For some of them, it might be useful to show the components. I think like operating margins in particular, just to see like how revenues and expenses are changing over time. I think we know that, like, for example, during COVID, revenues went down a lot, expenses went up a lot. That had a really significant effect on margins. What are we seeing since then? Have we seen, revenues stabilize, but expenses continue to increase? Really getting at like what what, is driving changes in some of these ratios over time in terms of different components.
Got it. That's a good suggestion. Thank you. Yeah. Let's call for any immediate feedback. If not, this will be another item that we'll aim to bring back in the fall. We'll see if it's feasible for the September meeting. We haven't set a date yet, but we are going to have our annual public hearing at the end of September. So that's the only reason, along with the dashboard work, we might need a little bit more time, I think, to work with these as we're prioritizing work products that we'll be prepping and hoping to roll out at the public hearing. But we'll work to get this back and sort of have another round of review with this group with kind of a draft of what these metrics actually look like over time and discuss again at that point. Yes, Katie?
Thanks, Meg. Just two quick things. One is I totally support Trevor's suggestion related to looking at those things that make money and those things that lose money. And I that's just really important, particularly when you're looking at health systems. And the other piece I would add is a caution as it relates to health systems, which was just alluded to, which is when you've seen one health system, you've seen one health system. So audited financial statements are definitely the right place to get as comprehensive a picture as you can. And we're all structured a little bit differently. And so just keep that in mind. Probably way easier in Maine to sort this out but when you start looking at trying to compare to other systems in particular, it's going to be extremely difficult because people account for things and governance structures look different in different places, and followed by financial structures. So to that end, I would just offer at any time, if you are interested in meeting with our financial team or members of our financial team, or I'm sure that, or the MHA, I'm sure David would be willing to meet. Randy has a ton of background in this. Just we're happy to walk through with you sort of what it looks like and be totally transparent and rather than having you try to make assumptions about what you're seeing.
Thank you, Katie. Yeah, we've definitely learned a little bit of that again by way of kind of conversations with Karen Lee and others who have been doing this work around like influence of whether entity is considered part of the hospital itself or a subsidiary of the system, so have at a high level, I think, a little bit of an understanding of what you're referring to there, but really appreciate the offer. And certainly I think as we're digging in and beginning to visualize some of this, maybe we can bring it back and would love to have an opportunity to ask some questions. It's interesting, Katie and I, even in digging in on this, had some thoughts about like, okay, but you can understand at a high level something like average age of plant, but really understanding how is that calculated and to what level of improvement does a building need before it influences that calculation has been interesting. We've sometimes come across anomalies in the data that have made us curious. So it might be nice to follow up and sort of ask like what happened here with a year-to-year change in some of those measures. So we'll certainly take you up on that when the time is right and appreciate the feedback. Anything else? I know it was a shorter meeting, but we did feel like we had a lot of substance to go over, particularly in this section, but glad to hear it sounds like there's a lot of similarities, I think, in feedback around kind of focusing on MHDO data. And I'm glad to hear that it looks like we did a good job, at least with a basic set of the metrics, but lots of good feedback here about going back and maybe revising those a little bit and making some additions as well. And I figured with it being a holiday week, no one would mind getting a little extra time back. So I'll do one last call if there's anything not related to the presentation today that anybody has to share, wants to ask questions about. Okay, great. Well, in that case, wish you all a happy 4th of July and a nice long weekend. And we'll see you at the beginning of September for our next scheduled meeting. Thanks, everyone. Bye-bye.
Thank you.
Thanks.
Well.
Bye-bye.